in the clinic, but also our scientific work in the field of fertility preservation for cancer patients. So this is, I suppose, a cancer specialist audience. I'm just going to click away those who come in now. Cancer specialist audience, clinicians, basic scientists, translational scientists. I have to say that this presentation will be mainly focused on clinical work, and we are specifically working with cancer patients where we focus not on cancer treatment, but on side effects from cancer treatment in the long term. So we are focusing on quality of life for the cancer survivors. Survivorship is becoming more and more important in in clinical research, but also in healthcare for cancers in general. These are some of my disclosures. So as you can see, I have been involved in oncofertility research from a FWO FNRS fund that has been granted to our department at VUB for the follicle biology research group, but also in joint research with UCL, Marie-Madeleine Dolmans from the ovarian transplantation group in UCL Louvain, and ULB Erasme for Isabelle de Meestre. Just as a situation of where the work is located, fertility preservation is a joint research activity between VUB and UZ Brussel. So for VUB, we have the follicle biology group focusing on female fertility preservation, headed by Ellen Ankaert, and the biology of the testis group, headed by Ellen Goossens. And at UZ Brussel, there is a department that is basically dedicated to fertility preservation, which can be either elective oocyte cryopreservation, also sometimes referred to as social freezing, women who would like to postpone maternity and freeze oocytes for the future. But then specifically here, relevant here is oncofertility preservation. So all the strategies that you can do to increase the options for cancer patients to become parents in the future. And the opinion has changed in the past decades, I can say. In many years ago, oncologists were not so much concerned about fertility issues and infertility in cancer patients because the options were very limited. Ovarian tissue freezing has evolved in the 90s of the last century, but oocyte freezing, oocyte cryopreservation, has only become a realistic option in the past 15 years or so. And it's since then that cancer specialists have also raised these concerns, and they basically talk about reproductive issues, and they refer cancer patients for fertility preservation. And studies have asked in many surveys published worldwide, have asked cancer patients whether there was an interest for them in fertility issues. And according to the studies, approximately 50% of young cancer patients do have reproductive concerns regarding cancer treatment and the effect on their future options to become parents. And this is repeatedly studied by many groups worldwide. And there is growing evidence that and that's from epidemiological studies, that cancer treatment does have an impact on the chances of having a child later on. Now, whether this is an effect purely from the cancer treatment and the effect on the gonads, or whether there is also a sociological or psychological impact, that's hard to say. But there is definitely a physiological impact from cancer treatment on reproductive organs, and that's mostly the case for breast cancer, leukemia, and cervical cancer, where these women, after they had cancer and when they are cured from cancer, they have on average a reduction by more or less 50% reduction of parenthood. So when compared with matched controls, their chances of having a live birth after cancer is reduced by 50%. And why this is so much the case can be explained by this graph. So when you see a cancer patient before she undergoes chemotherapy, we can actually distinguish different categories of young women. You have a category of women who have a high functional ovarian reserve, and these are women who will see that their functional reserve of follicles in the ovaries will drop as a result of the impact from the chemo. But then after chemotherapy, there will be a recovery of the ovarian function, and follicles will start to develop again after stopping the chemotherapy. But this recovery period is often unpredictable. It's from biology, we know that it takes more or less 4 to 6 months for a primordial follicle to... Sorry, I think you lost me at some point there, but it takes more or less 4 to 6 months for a primordial follicle to become a dominant follicle and to ovulate. But in many cancer patients, it takes much longer than 6 months. Sometimes it takes up to 2 years before a new plateau is reached for antral follicle number and optimal ovarian function. But then again, after that point is reached, the ovarian follicle loss will follow a more physiological course. But in some women, we see that they already have a rather low functional ovarian reserve before they even undergo chemotherapy, and then their risk is much higher of having no recovery at all and to have ovarian insufficiency and even premature menopause after chemotherapy. And it is, of course, for these women that the concern is highest to undergo strategies that could help them to avoid infertility after cancer. The problem is, it is very hard to distinguish really those patients who will benefit most from fertility preservation strategies. The recovery depends obviously on age of the patient. The younger the patient, the higher the chance of having ovarian recovery. And it depends also on the level of gonadotoxicity. And the anti-Mullerian hormone level, which is a hormone produced by the follicles in the ovaries, can be used as a guidance to predict the age of menopause, but cannot be used to distinguish between someone who will be infertile and someone who will not be infertile after cancer. And the anti-Mullerian hormone level before chemotherapy and the exposure to alkylating chemotherapeutic agents are the both parameters that are significantly related to diminished ovarian reserve after chemotherapy. 3 different categories of gonadotoxic chemotherapeutic agents, and obviously I'm not an oncologist, and I have to be honest in this. I always have to contact, of course, the oncologists to decide what we can expect in terms of damage to the ovaries, and so this is like a multidisciplinary approach before we counsel the patients regarding fertility preservation measures. Now, we know that 3 different pathways of follicle loss can be identified. There is follicle apoptosis, and this depends on the size of the follicle. In very small follicles, it's difficult to see from these images, but in very small follicles, primordial follicles and primary follicles, there is direct damage at the level of the oocytes, whereas in larger follicles, in secondary follicles, preantral and antral follicles, the damage is mostly done at the level of the somatic cells, the granulosa cells, and the oocyte will only become apoptotic in a secondary stage. Follicle activation is actually also a mechanism by which ovarian damage will occur, because chemotherapy will result in activation of several signaling pathways where the primordial follicles, instead of being in rest, they will become activated. And when you activate follicles, this means that they will, their number will decline, obviously. Fibrosis is also an important mechanism of ovarian damage. And several professional societies have issued guidelines for oncologists and hematologists regarding the fertility preservation strategies that exist. And there is consensus that cancer patients, when they are young and when they have a favorable prognosis, they should be counseled about fertility preservation strategies. And among the strategies, the oldest one is oocyte cryopreservation, which has become established as an option in 2011. Embryo cryopreservation can also be recommended, although it is probably more useful to cryopreserve oocytes than embryos, because if you cryopreserve embryos and you see that later on the couple no longer exists because of divorce, then that can be really dramatic, because we have seen patients who cryopreserve embryos, and then after chemotherapy, the patient is in remission from cancer, she's in menopause, but unfortunately the couple is no longer together, and all they have is cryopreserved embryos. And obviously the woman cannot do anything with these embryos if the couple no longer exists. Ovarian tissue cryopreservation has been experimental for a long time, but is no longer experimental. In 2019, the American Society for Reproductive Medicine has lifted the label of experimental, and this procedure can now be offered to young girls even, and also young women who have a high risk of gonadotoxic damage to their ovaries. It should not be offered, ovarian tissue cryopreservation, not be offered to women who are above 36 years of age, because then the quality of the follicles is lower and the number of the follicles is also lower. And also in women with low levels of anti-Mullerian hormone, this should also be discouraged to perform ovarian tissue cryopreservation. In vitro maturation of oocytes is considered an innovative option. It's no longer experimental. Only recently this experimental label was lifted, and ovarian tissue oocyte IVM, which I will talk about in a few minutes, is still experimental, and these approaches may be combined. Now, in Belgium, the situation has changed for the patients approximately 5 years ago. In 2017, the government has offered a reimbursement scheme for cancer patients, for female and male cancer patients, where they no longer had to pay themselves for these fertility preservation strategies. So freezing of sperm, freezing of testicular tissue, ovarian tissue, and freezing of oocytes is now fully reimbursed by the government in Belgium. Okay. Now, the huge change in the approach has actually been instigated by cryopreservation technology that was invented more or less 15 years ago in Japan. So vitrification is now the standard method of choice for oocyte cryopreservation and embryo cryopreservation, and it is highly efficient. And this is also the reason why oocyte cryopreservation is now number one as a strategy for fertility preservation. And the improvement of this technology in the lab is also remarkable in our clinic here in UZ Brussel, where we see that in 2015, the oocyte survival rate after vitrification was 75%, and nowadays it is at least 10% higher. So it means that if you freeze, if you cryopreserve 20 eggs in a patient, then on average 17 of them will survive the vitrification and warming process. There is an algorithm for the counseling of cancer patients, and this algorithm is mostly based on the available time frame that we have for these patients. If we do not have 2 or 3 weeks during which we can stimulate the ovaries, then the only option that we can offer is cryopreservation of ovarian tissue. If we do have 2 weeks available before starting the chemotherapy, then we can stimulate the ovaries and we can cryopreserve oocytes or embryos. So this is an important distinction between those two options based on the available time. And depending on this, we can also combine strategies. And this is actually something that we have been doing since more or less 10 years. Based on the available time frame, we discuss all the available options with the patient. For instance, if we have if we do not have 2 weeks available for stimulation, then we can perform an egg retrieval for in vitro maturation of oocytes, or we can perform ovarian tissue cryopreservation, but we can also combine these technologies in order to enhance the options for the patients. And an example of this is this young 29-year-old patient who was referred to us with a diagnosis of invasive early stage breast cancer, hormone receptor positive breast cancer, where the proposed treatment was neoadjuvant chemotherapy, which is standard approach these days. And we were allowed to stimulate the ovaries of this patient before starting chemotherapy. She had just stopped the combined oral contraceptive pill, and we performed the blood tests where we could immediately see the level of functional ovarian reserve of the patient. And here we see an anti-Mullerian hormone level of 3.39, which is completely normal, and an antral follicle count, which is the number of antral follicles that we could see in these ovaries, of 20 in total, which is also a normal, healthy level of ovarian reserve. So in this patient, and this is very small print, I apologize for this, in this patient, the day when she called us, we could not see her, but on the next day, we immediately performed the blood test, and we could immediately start stimulation of the ovaries. So there was no delay. We stimulated the ovaries with gonadotropins, and at the same time, we administered an aromatase inhibitor, letrozole, to keep the levels of estradiol in the serum of the patient low enough not to trigger proliferation of breast tissue. And it took 2 weeks for this stimulation to be achieved, and we triggered ovulation with a GnRH agonist. And 2 days later, we performed an egg retrieval, transvaginal egg retrieval. 13 eggs were collected, 9 of them were mature. These were frozen by vitrification, and the chemotherapy was started 2 days later. So this is actually the time frame which is rather common in our practice. It used to be much longer. In the early days of ovarian stimulation, this protocol was not available. But then I'm talking about at least 20 years ago, where it could take up to 4 weeks to stimulate ovaries. And then again, we also had to wait for the menstrual cycle to start before we could start stimulation. Nowadays, we can start stimulation of the ovaries at any time during the menstrual cycle, either in the beginning of the cycle or even after ovulation. You could ask yourself, well, yes, there you ask us to wait for 2 weeks before we can start chemotherapy. Is this actually healthy? Is this not unsafe for the patient? And then we have to look at the recent data in breast cancer patients here presented in Cancer Journal this year, more than 250 women where so this is a retrospective study where half of the patients had fertility preservation and the other half did not have fertility preservation. The hormone receptor status was about 50-50. Some had hormone receptor positive disease, some did not have it. And when we look at the incidence of relapse or even the incidence of death, there was no difference between those patients who had fertility preservation, who had a delay of 2 weeks, and those who could start chemotherapy much sooner. So the delay apparently does not have an impact on the recurrence or on the survival of breast cancer patients. And another quick word on why we can stimulate the ovaries at any time during the menstrual cycle. And this is based on the theory of the follicle waves in the ovaries, which was first discovered in animal models. And the idea is that follicles, antral follicles, can respond to follicle stimulating hormone at any stage. And this means that during the menstrual cycle, which takes on average 28 days, there are at least two different waves of follicle recruitment. So at any stage, you can give high enough doses of follicle stimulating hormone, and you will see that follicles will respond and will start to grow. So you don't have to wait for the menstruation before starting stimulation. Obviously, all this theory can be interesting, but do patients actually become pregnant when they come back to use their vitrified oocytes? And the answer is, well, yes, but it depends on the number of vitrified oocytes, of course. If a patient has 10 oocytes vitrified, which is the average number of eggs that we have after ovarian stimulation, then she can expect approximately 40% chance of a live birth if she uses all these 10 oocytes. And a lower number of oocytes will correspond to a lower chance of a live birth. Now we can also combine strategies, so we can stimulate the ovaries, and we can, before stimulation, we can remove part of an ovary, or we can perform a complete ovarectomy to combine the strategies and to enhance the options for the patients. But that's obviously in selected cases. What do the data from the publications tell us? Well, on average, 1 out of 3 women who return to the fertility clinic to use the cryopreserved oocytes will have a live birth with these oocytes. And this apparently this corresponds more or less to the same figure in women who cryopreserve oocytes just for social reasons. So basically, it does not really depend on the indication, whether you are a cancer patient who freezes her eggs or you want to freeze your eggs because you don't have a partner. The chances of having a baby with these eggs does not depend on the indication for freezing, but it just depends on the age at which you have your oocytes frozen. Is it safe to stimulate the ovaries in a breast cancer patient? Well, the answer apparently is yes, but studies have also shown that the administration of aromatase inhibitors, such as letrozole, do not have an impact on the stimulation itself. So it means that the number of eggs that you can get from a stimulation, whether you give letrozole or whether you don't give letrozole, the number of eggs is the same. And also, according to studies by Isabelle de Meester from Erasmus ULB, it was found that the tumor DNA level was mostly not increased in breast cancer patients when they had ovarian stimulation with letrozole. So based on these data, we can accept that this is a feasible strategy in breast cancer patients who have their tumor still in situ before starting chemotherapy. And there was in a large study in Sweden, there was no difference in survival in women who had fertility preservation with letrozole and women who had fertility preservation without letrozole. So actually, whether we have to give letrozole or not is still undecided in breast cancer patients. Now, this is a patient of 28 years who is referred to the hematologist for a diagnosis of acute lymphoblastic leukemia. The hematologist argues that she has to start chemotherapy as soon as possible. So there is no time to stimulate the ovaries here. We immediately perform a blood test to check the functional ovarian reserve. And again, this 28-year-old patient has good levels of anti-Mullerian hormone, has good numbers of antral follicles in her ovaries. So if we cannot stimulate the ovaries, what can we do? And the answer is that we performed a transvaginal collection of immature oocytes. So only a few days after the referral to our clinic, we performed a vaginal egg retrieval of 14 immature eggs, and we incubated these eggs in vitro, and 10 of these 14 eggs became mature eggs, and these eggs were vitrified for the patient. At the same time, when we collected the eggs, we asked the surgeon to insert a portacut, so we can easily combine things for the patient so as to accommodate optimal healthcare for the patient. And then on the next day, she could start her chemotherapy. And we also discussed a strategy of ovarian tissue cryopreservation in this patient, but according to current knowledge, we should not cryopreserve ovarian tissue in these patients before induction chemotherapy, because if you do that, then you will also cryopreserve tumoral cells, malignant cells, leukemic cells, together with the tissue, and there is a high risk of cancer relapse upon transplantation of ovarian tissue later on. So the idea is to give induction chemotherapy in this leukemic patient first, and then after a few rounds of induction chemotherapy, when there are no leukemic cells in the circulation anymore, then it is considered safe to cryopreserve ovarian tissue. Now, the in vitro maturation of oocytes is preceded by a transvaginal puncture of the follicles of the ovary, and this is what you can see here. So it's actually an easy procedure. It does not require any hormonal pretreatment, so this can be done at the spot, and the immature eggs that are retrieved can be incubated in registered IVM media. Now, obviously, this procedure cannot be done in everyone. You have to be psychologically mature enough to accept this type of procedure. So in young children, this is, of course, impossible. And also, you need to have a reasonably good number of antral follicles, because if this is not the case, then there's probably no point in performing this procedure. So in vitro maturation can be done in oocytes that are retrieved transvaginally, but it can also be done in oocytes that are retrieved when you perform ovarian tissue cryopreservation. And that's a relatively new approach, still deemed experimental. The question is, of course, when you remove an ovary, what should you do? Should you remove a complete ovary? And then you have a risk of inducing menopause artificially, because when a patient has only one ovary instead of two, then she will probably have an earlier age at natural menopause. And especially when she undergoes chemotherapy, this age at menopause will be even more reduced. That's the question. So the question is, maybe we should avoid complete oophorectomy in women who have only moderate risk of ovarian damage. And yes, so this is a recommendation. If the risk of ovarian damage is really high, then you remove a complete ovary, or in young children also you remove a complete ovary. If the risk of ovarian damage is not high enough, then ovarian biopsies are probably the better option. And when you remove an ovary, you can see the different compartments of the ovary. So in the center, what do you call it? Well, I forgot the name, but the cortex of the medulla of the ovary does not contain primordial follicles, only contains growing follicles. But it's really the cortex that you want to freeze, because the cortex contains primordial follicles. So when you see an ovary when you see an ovary in the dish, you would like to separate the cortex from the medulla. So this is what you do. You cut the ovary, you open the ovary, and you separate the medulla from the cortex, because it's the cortex that you want to cryopreserve, containing all the primordial follicles. And you cut the cortex into small pieces for cryopreservation. And after doing this, what you find in your culture dish is debris tissue, and in this debris you can filter it, and you will find small cumulus oocyte complexes that have just dropped out from the ovary while you were cutting the ovary. And these small cumulus oocyte complexes can be incubated in culture media, can be incubated for 30 to 40 hours. And after incubation, between 40 and 50% of these cumulus oocyte complexes will result in a mature oocyte. And these oocytes can then be cryopreserved. So this is what we call ovarian tissue oocyte IVM. It's a relatively novel strategy. And we have, last year, we published the first live birth worldwide of this procedure in our clinic. Now, in vitro maturation of oocytes, obviously we can say a lot about that technique, but time is short. So I just want to focus on what we are doing here at VUB to improve the efficiency of in vitro maturation of oocytes. And the idea is to incorporate a sort of arrest phase. So we want to keep the oocyte in prolonged arrest to give the cytoplasm more time to become mature. So the idea is to arrest meiosis progress in these oocytes by giving cyclic AMP analogs. Also, we have to give oocyte secreted factors in order to enhance the potential of this oocyte. And then after this arrest stage, we can incubate these oocytes in vitro media. And in this stage, the meiosis will resume, of course, and then you will have a metaphase 2 oocyte. And the idea of this program is to increase the efficiency of IVM for the cancer patients. And this is what we are doing in the lab at Follicle Biology Group. And in the clinic, we have seen so far a couple of dozens of patients who had the combination of ovarian tissue freezing and ovarian tissue IVM. And on average, we had 6.7x per patient vitrified. And in the patients who came back in remission from cancer, we had 3 live births so far using this technology. So it is experimental, but it can already be applied in the clinic. And this is a patient. This is actually the first patient who had a live birth worldwide in our clinic. So she had Hodgkin lymphoma, and she had to undergo aggressive chemotherapy, BCOP. You know better than I do. And she had good levels of functional ovarian reserve. She was a contraceptive pill user. Looks like something went wrong. Sorry about that. She wanted fertility preservation because she was still young. Obviously, we combined vaginal egg retrieval for IVM with removal of a complete ovary, and when we did so, we had only one mature egg from the oocytes that were retrieved vaginally, but we had 7 mature eggs from the oocytes that were retrieved from the ovary. So this made a total of 8 mature eggs vitrified for the patient. So the patient started her her cancer treatment, and 2 years later she was in remission from cancer, and she wanted to have a baby. Unfortunately, she was in menopause. The ovarian function was completely absent, and it was decided to use these oocytes that she had frozen before cancer treatment. And all 8 eggs that were cryopreserved, except one, so 7 out of 8 survived the vitrification warming process, and the 7 eggs were injected with sperm from her husband, and 3 embryos were generated, and 1 embryo was transferred, and she delivered a healthy baby. So this was just to actually give you an illustration of what can be done for these cancer patients who have no time for ovarian stimulation because of the urgency, and in whom ovarian tissue cryopreservation is an option. But if you have both options next to each other, then this in vitro maturation of oocytes is probably less aggressive for the patient, because it does not require a procedure for transplantation, and no surgery is needed. Nevertheless, the protocol for in vitro maturation of these oocytes is still suboptimal, and further research is needed to increase the efficiency of in vitro maturation of oocytes for these cancer patients. Transplantation of ovarian tissue is another option, and so far more than 200 babies have been born worldwide after ovarian tissue transplantation, of whom 50% are conceived naturally, so without IVF, and this is also quite remarkable. Here at VUB UZ Brussel, we have so far 3 live births after 7 women who had ovarian tissue transplantation. And there are several techniques that you can apply for this transplantation. One technique is presented here, where you transplant the frozen ovarian tissue to the contralateral ovary. And this can seem a bit difficult, and it is really difficult. It is more difficult than grafting the tissue to a peritoneal window, and actually these 2 techniques have equivalent results. And this is an illustration of how to transplant the tissue to the contralateral ovary. If the video wants to start, please. And I think I have a technical problem because the video doesn't want to start. No. Okay, sorry about that. Yeah, okay, so sorry about the video, but I just wanted to show you a patient who had uterine cancer. So the uterus had to be removed in this patient. So we transplanted ovarian tissue to her pelvis, and this was for the idea of gestational surrogacy. So she wanted to have oocytes that could be fertilized with her husband's sperm, and then the embryos could be transferred to the uterus of another woman. And here you see that 3 months after transplantation of ovarian tissue, she developed follicles. The follicles were aspirated and the oocytes were injected with sperm, and we had some embryos, and then these embryos were transplanted to the uterus of a gestational carrier. Now, the problem with ovarian tissue transplantation, and we are coming to the end of this presentation, the problem is the loss of follicles after transplantation, because when you transplant ovarian tissue, obviously it takes a couple of days before you have this neoangiogenesis and the vascular invasion to this ovarian tissue graft. And as a result of this, there is follicle loss, follicle activation. And this is what you can see here. This blue line is the anti-Mullerian hormone level that goes up very briskly after transplantation, and then it comes down again. And the idea is in the future, the idea is to administer recombinant AMH when you perform ovarian tissue transplantation, just to keep the primordial follicles quiet so that they do not become activated after transplantation. So ovarian tissue transplantation was considered unsafe in hematological cancer patients, in leukemia patients, but recently the first live birth has been reported after ovarian tissue transplantation in the leukemia patient in Israel. And the idea is to give chemotherapy before removing the ovarian tissue, so as to make sure that there is no leukemic cell invasion in the ovary. And obviously, before transplantation, all of these patients need minimal residual disease screening, just to be sure that we do not transplant leukemic cells back to the patient. We should not forget the uterus, of course, and the function of the uterus that can be dramatically impaired due to pelvic irradiation, because so far I've been talking about chemotherapy, but many patients also have radiotherapy of the pelvis. And there it is important to keep in mind that if in adult patients the uterus has been irradiated with more than 45 gray, then pregnancy should not be recommended because of the high risk of loss of the pregnancy. We can also administer hormonal components during chemotherapy, and the idea is to administer gonadotropin releasing hormone agonists during chemotherapy, and this could have a protective effect for the follicles. And based on the data from meta-analysis, it was shown that women who had GnRH agonists during chemotherapy, breast cancer patients, they had a higher chance of remaining fertile after cancer. But it did not appear to work at the same level in women with lymphoma. So in lymphoma patients, it is not recommended to administer GnRH agonists. So here I have come to the end of my presentation, and I hope you enjoyed it, and I'm obviously